Hello everybody and welcome to our module on cystic kidney disease. Let's start by talking about autosomal dominant polycystic kidney disease, which most people refer to as ADPKD. This is a disorder that is inherited, and children who have this disorder are born with microscopic cysts at birth. Even though they have these cysts in the kidneys, they're too small to visualize with ultrasound, and the kidneys will appear normal at birth and in childhood. The cysts slowly develop and enlarge over many years, and that leads to clinical symptoms that present in adulthood. And as I said before, this is an inherited disorder caused by mutations of two genes called APKD1 or APKD2. Shown on the left are two kidneys from an adult with ADPKD. You can see that the kidneys have multiple cysts in lots of different sizes. These enlarging cysts essentially destroy the kidney tissue, leading to renal failure. On the right side of the screen is a CT scan from a patient with ADPKD. You can see that the kidneys are enlarged and bumpy. That's consistent with polycystic kidney disease. In addition to the kidney problems, ADPKD is associated with many non-renal problems as well. In particular, these patients often develop Barry aneurysms in the brain, which can lead to subarachnoid hemorrhage, and this is a common cause of death in people who have ADPKD. These patients can also develop liver cysts, and they're also at increased risk for mitral valve prolapse. So the classic presentation of ADPKD is going to be a relatively young adult, probably someone in their 20s or 30s who presents with high blood pressure. And remember, the onset of hypertension at a young age is very uncommon and almost always suggests a secondary cause of hypertension. In the case of polycystic kidney disease, the hypertension is believed to be through increased activation of the renin-angiotensin-aldosterone system. There can also be high blood pressure if renal failure is advanced. Most patients with advanced renal failure have hypertension. Other findings that may be present include hematuria. There can be red cells in the urine. As I said before, this disease ultimately leads to renal failure, so that can already be present when patients present. And then finally, especially in board questions, they will often describe a family history of sudden death, and that is a death due to aneurysm in a family member who had the same disorder. The best test to make the diagnosis is a renal ultrasound, and in patients who have early onset hypertension, a renal ultrasound is a standard test to identify evidence of any kidney problem really, but it can also easily identify polycystic kidney disease. It will look like this picture on the right side of the screen with multiple cysts present. The management of patients with ADPKD mostly involves treating the blood pressure and monitoring the kidney function. But there is one drug that has been shown to slow the progression of the disease, and that's tolvaptan. Tolvaptan is an antagonist to vasopressin V2 receptors. These are the receptors found in the collecting duct that cause water to be reabsorbed from the nephron of the kidneys. And it turns out if you block this action, not only do you block the effects of vasopressin on the nephron, but you block the effects of vasopressin on cysts. This slows the expansion of cysts in clinical trials. Patients with ADPKD who took tolvaptan had lower total kidney volume compared to placebo patients. Tolvaptan has also been shown to slow the decline in GFR. Because tolvaptan is expensive and because the progression of renal disease in ADPKD is very slow, tolvaptan is usually reserved for patients who are at high risk of progression. These are patients thought to likely need dialysis in the relatively near future if not treated with a drug. And then lastly, because these drugs block the reabsorption of water from the nephron, they cause water to go out in the urine, and therefore they can easily cause the patient to develop an abnormal sodium concentration. So for that reason, tolvaptan is contraindicated in any patient who has an abnormal serum sodium, especially patients with hypernatremia. Those patients can see their hypernatremia get much worse if you give this drug and cause water to go out in the urine. In healthcare in the United States, it's very easy to obtain imaging studies on patients, so many patients have imaging of their abdomen done for one reason or another, and often it will incidentally identify cysts in the kidneys. This is an example of a patient with a couple of kidney cysts shown here on the right side of the screen, and these are often picked up when an ultrasound is done for some other reason. Anytime a cyst is identified in the kidneys, the concern is that it may represent a kidney malignancy. And in order to decide how likely it is that the cyst represents malignancy, we categorize cysts as either simple or complex. Simple cysts are usually benign. They're commonly found in normal kidneys. Usually the patient has no symptoms from the cyst, and rarely do simple cysts require treatment. Complex cysts, and we'll talk in a minute about what makes a complex cyst complex, but complex cysts could be malignant. These are often followed up with more imaging studies. They sometimes go for biopsy, and sometimes even the cyst is excised. Shown on this slide is an example of a simple cyst by ultrasound on the left and a complex cyst by ultrasound on the right. Characteristics of simple cysts are that they are usually thin-walled, They are not septated, meaning that there are no walls within the cyst. If you look at this cyst on the left side of the screen, you can see it's all black in the middle and clear. There are no walls going through the blackness in the middle. That means it's non-septated, meaning it has no walls. If you perform a CAT scan or an MRI on a renal cyst, it will not enhance if it's simple. So enhancement implies that contrast material can get into the cyst, and that implies it has blood flow, and that's typical of malignancies. Simple cysts are usually filled with fluid, and therefore they will not enhance on CT or MRI when you inject contrast material. And then finally, simple cysts are usually homogeneous in appearance. In contrast, complex cysts, like the one on the right, typically have thick walls. They're often irregularly shaped and multilocular, and by multilocular, I mean that they have walls in different compartments within the cyst. If you look at this complex cyst on the right, these are walls within the cyst. That's evidence of septation. It's also called multilocular, and that's a presence of a complex cyst. Complex cysts will enhance when you image them by CT or MRI, and they are usually heterogeneous in appearance, like this one shown on the screen here. And that concludes our module on renal cysts.